Hello, my name is David McComb. I am a registered nurse in the emergency department at York-Presbyterian, Weill, Cornell.
And I'm Carolyn's son. I'm an assistant professor at Hunter Bellevue School of Nursing in Manhattan.
And the title of our research project is Identifying High-Risk Maternity Through Telehealth. Women who use the emergency department for obstetric and gynecological complaints are more likely to be younger women of color who have multiple maternal risk factors. Roughly 3 out of 4 teenagers screened for sexually transmitted diseases during an ED visit become pregnant within 4 years of testing. These types of ED visits identify women who are at high risk of developing maternal complications and is an opportunity to offer resources as an intervention. Identifying women of color using ED services for obstetric reasons is clinically important due to the disparity in maternal mortality in the United States. Women of color die from childbirth-related events at a higher rate than white women, even when we adjust for their age, income, level of education, and neighborhood. For each maternal mortality, there are about 100 mothers who experience complications during childbirth that impact their overall health in both short and long term. The current management of high-risk pregnancies focus on hypertension, sepsis, and hemorrhage that surround the immediate birth period. However, distinguishing maternal risk factors and healthcare interactions, such as ED visits for obstetric reasons, provides us the ability to follow expert recommendations of establishing surveillance over a wider period of pregnancy. Telemedicine, the use of phone, video, or text to conduct a remote medical visit, has been effective in delivering care to high-risk obstetric patients. The emerging format of telemedicine was a novelty until the restrictions imposed by the COVID-19 pandemic led to widespread adoption of the practice. The majority of telemedicine was for health conditions other than COVID-19 infections. Telemedicine is not without its own structural challenges of unequal access based on internet services, cost, and availability of same language providers. This study aimed to examine the use of acute care telemedicine for obstetric and gynecological reasons as a substitute for in-person ED visits and describe the diagnosis of women compared to their declared race and ethnicity. Our objective was to identify disparity in ED visits carried out as telemedicine visits, benefiting from the amplification of service use as a result of the COVID-19 pandemic.
This study was a retrospective chart review of acute care direct-to-consumer telemedicine service within a single large metropolitan hospital between October 2020 and October 2022. Visits were conducted by a board-certified emergency medicine provider. Telemedicine users self-initiated the visit based on information obtained through public advertisements. During the registration process, the user could opt to declare their race and ethnicity with the following choices: unknown, other, not described, Black or African American, Latino, white, AAPI, or AIAN. Inclusion criteria were those who were registered for the visit as a female, lived in New York City between the ages of 15 and 54 years old, received an ICD-10 code visit for a reason that was OB or GYN related, such as pregnancy, contraceptives, vaginal bleeding, and dysuria. Because there was not a possibility of physical exam or laboratory tests within the virtual format, dysuria was examined as it often is a complaint of a sexually transmitted disease. Descriptive statistics and tests for associations were conducted using Pearson's chi-square tests of independence to assess the relationship between declared race and ethnicity, age, and the resulting ICD-9 code from the telehealth visit. Here's a list of the different ICD-10 codes that we searched for in the charts. The study was approved by New York-Presbyterian and Weill Cornell Hospital as exempt.
The study criteria yielded an N of 694 charts over the 2-year period. The average age of the user was 33 years old. Most of the patients using telehealth were white, but a sizable portion were Latino. Only 6 patients, 0.9%, declined to self-identify a race or ethnicity. The most frequent diagnoses were for a urinary tract infection. 20 patients were missing a diagnosis. There were no statistically significant correlations between age group and diagnosis. However, we did find that there was a statistically significant difference between race and ethnicity and diagnosis. Women of color and Latino women were more likely to be diagnosed with an abnormal uterine and vaginal bleeding when compared to white women, whereas white women were more likely to be diagnosed and treated for UTIs than women of color or Latino women.
After the initial surge of cases of COVID-19, when telehealth became more feasible, we found that 674 visits were obstetric-related visits. This demonstrates an opportunity to initiate continued follow-up for high-risk populations. The study demonstrates that a diverse group of women use telehealth for obstetric-related visits. Interventions should be developed to ensure there is health equity across the groups. Because more white women received a diagnosis of UTI, they were likely more often given an antibiotic, as this is the standard treatment for a UTI. Women of color may go undiagnosed, as abnormal vaginal bleeding is a broad term that could indicate miscarriage, uterine cancer, etc., and is not a specific treatable diagnosis. Public health surveillance has always been built awkwardly into emergency medicine. The disparity in in-person ED visits is presumed to be a lack of access to medical care. The use of telemedicine can be thought of in similar terms with the added lack of mobility or time to travel to the hospital. The digital infrastructure of telemedicine, the ability to instantly reach out to a person, is extremely advantageous to the surveillance of maternal risk factors, among other medical conditions. Future iterations of our study should follow the cohort prospectively, examining pregnancy status and outcomes. Determining that the cohort has legitimate high maternal risk would further validate the need to create a telemedicine surveillance program. Limitations of this study include the fact that this study was limited to a single hospital and service. The chart data was not robust enough to reveal patient return visits or follow-up in-person appointments. The use of ICD-10 codes constrains our analysis as their design leans toward reimbursement. We are also limited by the concept of race, which is a social construct, an artificial data point. The chief complaint provided by the patient in their own words was not recorded in the data set and may have provided additional insight into the reason for using the platform. It was not possible to discern the pregnancy status of the patients diagnosed with abnormal bleeding. There may be a provider difference in the ICD-10 diagnosis codes used for similar complaints. Future studies could explore differences of diagnosis by providers, race and ethnicity, or gender to determine whether certain providers may be more or less biased to some groups.
In conclusion, there is a difference in the resulting telemedicine visit diagnosis compared to a patient's declared race and ethnicity. The recommendation of groups convened for maternal mortality recommend longitudinal interventions to augment the current initiatives that surround birth. The technological boost provided by the COVID-19 pandemic has reduced the barriers to using video conferencing platforms. The use of telemedicine infers that the end user is capable and willing to engage the digital format as a healthcare delivery pathway. Working with expert recommendations, nursing interventions can be built into these telemedicine services.
Thank you for listening to our presentation.